Welcome to Deep Dive Ortho, where we distill complex medical topics into essential, actionable insights for your practice. Today, we're navigating the intricate and often surprisingly vulnerable world of hand vascularity. The hand is an engineering marvel, isn't it? Critical for almost everything we do, and its blood supply is absolutely paramount. Not just for daily function, but for recovery from injury, and even as a window into broader systemic health. Understanding its circulation and knowing how to swiftly and accurately assess it, well, it's a cornerstone of modern orthopedic and hand surgery. We're incredibly fortunate to have with us today a true expert in this field. His deep understanding of orthopedics will guide us through the nuances of hand vascular health. We'll be exploring how you evaluate blood flow, diagnose issues from common conditions to dramatic acute injuries, and ultimately how we strive to preserve hand function in the face of diverse challenges. So let's unpack this crucial area of clinical knowledge and discover what it all truly means for you in your day-to-day work. The intricate vascular network of the hand and initial clinical assessment. To really grasp the essence of hand vascular health, we first need to appreciate the remarkable anatomical design. It keeps our hands perfused, doesn't it? It's an incredibly redundant system, almost like the body's very own sophisticated backup plan. Could you perhaps paint a picture of the hand's primary vascular supply for us?
Absolutely. It's a fascinating system, truly. The artery, the blood supply to the upper extremities, starts from major arteries in the chest, the subclavian arteries. These then transition into the axillary and brachial arteries as they move down the arm. As the brachial artery passes the elbow, specifically the antecubital fossa, it cleverly splits. It divides into the two main players for the forearm and hand, the radial artery and the ulnar artery.
The two key players.
Exactly. The radial artery runs along the thumb side, the lateral side of the forearm, while the ulnar artery courses along the little finger side, the medial side. But what's truly remarkable and vital for hand function is how these two arteries then form an intricate, interconnected network within the hand itself through what we call the palmar arches.
Right, the arches, like vascular highways in the palm.
Precisely. Think of them like that.
Yeah.
You have the superficial palmar arch, which lies closer to the surface. It's primarily fed by the ulnar artery, with a smaller contribution from the radial artery's superficial branch. This arch is complete in about 80% of individuals, providing a crucial safety net.
80%, okay.
Then you have the deep palmar arch. It sits a bit deeper, mostly supplied by the radial artery's deep branch, and with a smaller contribution from the ulnar artery. This deep arch is even more consistently complete in about 97% of patients.
Almost always complete then, the deep one.
Yes, very reliable.
Yeah.
And these comprehensive arches then give rise to the digital arteries, which are the smaller vessels ensuring robust blood flow to all your fingers and thumb. This dual supply and extensive arch system is precisely why the hand can often tolerate injury to one major vessel, thanks to that built-in redundancy.
That detailed anatomical picture truly highlights the body's incredible design for redundancy. It's quite amazing. But if those built-in safety nets are compromised, how do we spot it quickly? Before we even consider advanced diagnostics, what are those crucial first steps? The initial clinical assessment that can give us immediate insights at the bedside, perhaps in a busy clinic or an acute trauma setting.
You've hit on a critical point. Initial assessment is fundamental. It's readily available and often provides incredibly powerful insights. We always begin with a thorough inspection, looking at the skin. Discoloration, for instance, is a huge clue. A white or pallid appearance often suggests arterial insufficiency, meaning not enough blood getting in.
Right.
A bluish or purplish hue can point to venous congestion, meaning blood is struggling to get out. And of course, redness or erythema is a classic sign of infection or inflammation. Beyond just color, we also meticulously look for what we call trophic changes.
Trophic changes, could you expand on that?
Yes, these are subtle but telling signs of long-standing vascular problems, or perhaps a derangement of the sympathetic nervous system. Things like altered hair growth patterns or changes in sweat production on the skin. They're often missed but can speak volumes about chronic compromise.
Okay. Subtle but important.
Definitely. Then palpation is equally crucial. We check the temperature of the hand. Is it warm, which might indicate infection or inflammation, or is it surprisingly cool, which strongly suggests underlying vascular pathology, a lack of adequate blood flow? Then feeling the radial and ulnar pulses is paramount. We're not just looking for their presence, but their quality, their width.
And comparing sides.
Absolutely. Critically, any asymmetries between the upper extremities. A diminished or absent pulse in one hand compared to the other should immediately raise a red flag. It could signal a proximal arterial issue, perhaps even something like an embolism or a compression syndrome. We also gently examine for full engorged veins, which can hint at venous congestion, and feel for any masses or non-healing wounds, particularly at the fingertips, as these can be direct manifestations of compromised vascularity. It's about putting all these pieces together from a basic physical exam.
And what about capillary refill time? It's such a simple test. We learn it early on. How quickly can that give us a vital clue about peripheral perfusion and maybe even insights into the patient's overall systemic status?
Capillary refill time, or CRT, is indeed exceptionally quick, simple, and remarkably useful. It assesses both peripheral perfusion and a patient's intravascular volume status, especially in acutely unwell patients. It offers an immediate, real-time snapshot.
So how do you perform it correctly?
You gently apply manual pressure to the ventral surface of a finger or toe's discal phalanx until the nail bed blanches, turns completely white. You maintain this pressure for about 10 seconds, then release it. The time it takes for the normal color to return to the digit is the CRT,
And normal is?
typically less than 3 seconds. If it takes longer, that's a red flag.
Okay.
Now, while it's a powerful and accessible tool, it's crucial to be aware of factors that can interfere with its validity and interpretation. Ambient temperature is a big one. A cool room can artificially prolong CRT, even in a perfectly well-hydrated patient.
Right, that makes sense.
Patient age also plays a role, with CRT generally increasing slightly with age, and baseline CRT tends to be lower in males. Skin pigmentation and even the presence of nail polish or artificial nails can affect accuracy. Furthermore, you can get intra-observer and inter-observer variability, meaning results might differ slightly between examiners or even if the same examiner repeats the test.
So it needs careful interpretation.
It does. But despite these variables, its immediate availability and ease of use make it invaluable. For instance, in septic shock, the powerful insight from recent research is quite striking. Normalization of CRT has been shown to be as effective as lactate levels in guiding fluid resuscitation strategies.
Really, as effective as lactate.
Yes. Think about that. A simple bedside test can truly shift acute care management, especially when advanced labs aren't immediately available. In hemorrhagic shock, a prolonged CRT is a clear indicator of Class 3 or 4 shock, reflecting significant blood loss. Class 3 is about 31 to 40% blood loss with hypotension, and Class 4 is greater than 40% with altered mental status. So it's a quick, objective sign that can help triage and guide management when other, more invasive measures are not immediately feasible. It's a testament to how much information a simple observation can give you. 2. Raynaud's phenomenon. More than just cold hands.
So if that bedside assessment points towards something more chronic and complex, perhaps like the often misunderstood Raynaud's phenomenon, what are we truly looking at then? Many patients simply describe their fingers getting cold, but it's clearly more than just that simple feeling, isn't it? Could you elaborate on what Raynaud's really is, and crucially, why differentiating between its primary and secondary forms is so important in clinical practice?
Raynaud's phenomenon is a fascinating and, as you say, often distressing clinical syndrome. It's characterized by episodes of vasospasm, essentially an overreaction and narrowing of the small arteries and arterioles, primarily in the digits. These episodes lead to distinctive triphasic color changes that you'll see in patients. Initially, the digits turn white or pallid. That's the ischemic phase, indicating a temporary but severe lack of blood flow.
The white phase.
Yes. This is then followed by a blue or cyanotic phase, as the residual blood in the capillaries becomes deoxygenated. Finally, the digits turn red or erythema. This is the reperfusion phase, as blood flow returns, often with a tingling or painful sensation.
White, blue, red. The classic sequence.
Exactly. And these attacks can be triggered by cold exposure, emotional stress, or even certain medications. Now, the distinction between primary and secondary Raynaud's is absolutely critical. It completely dictates your diagnostic pathway and management strategy. Primary Raynaud's is generally considered benign. It typically presents between ages 15 to 30, is more common in young females, and often has a familial component. The key insight from those remission rates is interesting too. For many, especially young females with primary forms, it's not necessarily a lifelong sentence. Studies suggest remission in up to 64% of cases.
That's quite a high remission rate. Reassuring for some patients, perhaps.
It can be. Patients with primary Raynaud's usually experience symmetric episodic attacks without evidence of peripheral vascular disease, and they typically present with a negative ANA, anti-nuclear antibodies, which are a key marker for many autoimmune conditions. Crucially, you won't see signs of tissue damage like gangrene or digital pitting in primary cases.
Okay, so primary is generally less worrying in the long run. What about secondary?
In stark contrast, secondary Raynaud's is far more serious. It's associated with an underlying systemic condition. most commonly a connective tissue disease, such as systemic sclerosis, lupus, dermatomyositis, or mixed connective tissue disease. In secondary forms, the attacks are typically more frequent, more painful, and often asymmetric.
Key symmetric, that sounds like a key difference.
It is. And they can be complicated by severe digital ischemia, leading to painful ulcerations, digital pitting, those tiny, often painful indentations on the fingertips, necrosis, and even gangrene. In the most severe cases, autoamputation can occur, which may necessitate surgical intervention. Digital ulcerations can also become secondarily infected, potentially leading to osteomyelitis. The presence of these more severe complications is a significant red flag that mandates immediate and thorough investigation for an underlying systemic disease.
So missing that distinction could have really severe consequences for the patient.
Absolutely. Delaying diagnosis of an underlying connective tissue disease can significantly impact long-term outcomes.
That certainly drives home the urgency of getting to the bottom of it. What specific clinical clues, then, might raise a red flag for secondary Raynaud's in a patient presenting with these symptoms, prompting us to dig deeper?
Several clinical clues should immediately heighten your suspicion for secondary Raynaud's. These include an age of onset greater than 40.
Older onset.
Yes. Male gender, as primary, is more common in young females, and especially the presence of digital ulcerations or pitting scars. These are the hallmarks of actual tissue damage, a major red flag. Asymmetric attacks, meaning the phenomenon affects one hand or digit more severely than others, are also highly suggestive of a more systemic problem. Additionally, ischemic signs extending proximal to the fingers and toes, rather than being confined solely to the digits, point towards a more widespread vascular issue.
And you mentioned a specific investigation earlier, nail fold capillaroscopy.
Yes, a key non-invasive diagnostic technique that provides invaluable insights is nail fold capillaroscopy. This involves examining the nail bed capillaries, typically of the fourth and fifth digits, due to their better translucency, using an ophthalmoscope, perhaps set at 10 to 40 diopters, or a dedicated capillaroscope. What we're looking for are abnormalities in the capillary structure. Early abnormal findings include few capillary hemorrhages and enlarged capillaries. A more active pattern might show moderate capillary loss, frequent giant capillaries, and a disorganized vascular architecture, almost like a chaotic mess of vessels.
Giant capillaries.
Yes, abnormally dilated capillary loops. A late pattern, ominously known as dropout, indicates severe capillary loss with extensive avascular areas and ramified or bushy capillaries. These abnormalities are strongly associated with underlying connective tissue diseases. For instance, one large study of Raynaud's patients found that systemic sclerosis developed in over 25% of those with an abnormal capillary pattern. But that figure jumped to nearly 80% in those with both abnormal nail fold capillaries and a specific autoantibody.
Wow, 80%. That's a huge predictive value.
It is. That group was 60 times more likely to develop systemic sclerosis than those with neither predictor. It really underscores the prognostic power of this simple, non-invasive test. It's a window into the microcirculation.
Beyond the clinical presentation, the pathophysiology sounds incredibly complex, involving multiple body systems. Help us understand what's truly going on at the vascular level that leads to these dramatic and often painful changes. It's almost as if the on switch for constriction is stuck, isn't it?
You've captured it perfectly. The pathophysiology of Raynaud's is indeed multifaceted, and we're still unraveling all its complexities. But what we do know is it's this really intricate dance between your blood vessels, the blood itself, and your nerves. At its core, in patients with Raynaud's, the digital arteries constrict far more strongly and for longer durations than they should. There appears to be a significant imbalance in the local regulation of blood flow. Vasoconstrictors, like endothelin-1, are overactive.
So, too much squeeze.
Exactly. While vasodilators, such as nitric oxide and prostacyclin, are deficient, this essentially tips the balance decisively towards constriction. Intravascularly, several factors contribute. There can be platelet activation with increased thromboxane levels, defective fibrinolysis, which impairs the body's ability to break down clots, and white blood cell activation, contributing to inflammation. Your red blood cells might even exhibit reduced deformability, making it harder for them to squeeze through narrow capillaries, and overall blood viscosity can increase.
So the blood itself becomes part of the problem.
Precisely. All of this can lead to repeated episodes of ischemic reperfusion injury, which generates oxidative stress and further damages the microvasculature over time. Neural abnormalities also play a significant role. There can be impaired vasodilation due to a deficiency in calcitonin gene-related peptide. Crucially, there's often increased sympathetic adrenergic nerve activity, which primarily controls arteriovenous anastomoses involved in thermoregulation. When cooling occurs, this system goes into overdrive, causing alpha-2C adrenoreceptors, think of them as tiny constrict switches, to move to the cell surface. This enhances the sensitivity of the vascular smooth muscle to calcium, amplifying vasoconstriction and leading to those dramatic color changes.
Fascinating mechanism.
It is. And other systemic factors like cigarette smoking, genetic predispositions, and even hormonal influences, for instance, during the pre-ovulatory period, can significantly impact symptoms. It's truly a complex symphony of dysregulation, making it a challenging condition to manage.
Given these complex mechanisms and the potential for serious complications, particularly in secondary Raynaud's, what are the current treatment strategies? Starting with those simple lifestyle changes every patient should know about, right through to more advanced medical therapies.
Therapy for Raynaud's always begins with fundamental patient education and lifestyle modifications. And these are incredibly powerful first steps. This includes meticulous avoidance of sudden cold exposure and rapid temperature changes. Advise patients to consistently keep their hands and feet warm, and importantly, to maintain total body warmth, as core body temperature directly affects peripheral circulation.
So wearing a hat can help your hands.
Absolutely. Patients should definitely be counseled to avoid tobacco and caffeine, both of which are potent vasoconstrictors and can severely exacerbate symptoms. Sympathomimetic drugs like decongestants, amphetamines, and methylphenidate should also be avoided. For individuals whose Raynaud's is specifically vibration-induced, perhaps from using tools like jackhammers, discontinuing the use of such vibratory tools is key.
Makes sense. And if those lifestyle changes aren't enough?
When these conservative measures are insufficient, medical therapies come into play. Calcium channel blockers are the most common and practical first-line treatment. These drugs act as vasodilators by directly relaxing vascular smooth muscle and can also inhibit platelet aggregation. Nifedipine is widely used, typically at 30-60 milligrams per day, assuming the patient's blood pressure permits. A meta-analysis showed that calcium channel blockers were associated with about a 33% reduction in severity and a significant decrease in attack frequency.
So they are quite effective.
They can be, yes. Other effective calcium channel blockers include nisoldipine, amlodipine, felidipine, and isradipine. If calcium channel blockers aren't tolerated or aren't effective, losartan, an angiotensin II receptor blocker, has shown promise in reducing the severity and frequency of episodes.
What about the more severe cases with digital ulcers?
Right, for more severe digital ulcerations, particularly in scleroderma patients, intravenous Elafrost, a prostaglandin analog, is a key medication. It's a potent vasodilator and inhibitor of platelet aggregation. It effectively decreases attack frequency and severity, and crucially prevents or heals digital ulcers, with effects that can be prolonged even after the infusion.
So a powerful tool for severe cases.
Indeed. Endothelin receptor antagonists like bosentan can reduce the incidence of new digital ulcers, though they may not significantly increase the healing rate of existing ones. Phosphodiesterase inhibitors, such as sildenafil, vardenafil, and tadalafil, also show benefit by promoting vasodilation through increased nitric oxide synthesis. While topical nitrates have generally shown limited efficacy and can cause side effects like headaches, statins, despite insufficient evidence for standard therapy, might offer vascular protective effects.
And anything else on the horizon?
Well, botulinum toxin A is an exciting area of active investigation. It has potential to inhibit sympathetic vasoconstriction and is being explored as a treatment option, particularly in recalcitrant cases. But always remember, prompt referral to a rheumatologist is encouraged to evaluate for underlying rheumatologic conditions and help guide this comprehensive, often multimodal therapy. 3. The Allen test. Assessing hand collateral circulation.
Moving now from chronic conditions to acute assessment, the Allen test. It's a clinical maneuver many of us are familiar with, particularly before radial artery procedures like cannulation or blood gas sampling. It's been around for decades, yet its utility is still sometimes debated, isn't it? Could you walk us through the significance and methodology of the Allen test and its modified version, and perhaps shed some light on why that debate exists?
The Allen test is indeed a crucial screening technique. It's used to assess the collateral blood flow to the hand. Specifically, it evaluates the patency of both the ulnar and radial arteries, and critically, the completeness of the palmar arch. This assessment is vital before any procedure that might potentially compromise the vascular supply through either the radial or ulnar arteries. Think arterial puncture, cannulation, or artery harvesting for grafts, for example, in coronary artery bypass surgery.
Because you don't want to compromise the main supply if the backup isn't working.
Exactly. The radial artery, being easily palpable, is often chosen for these procedures, but a negative Allen test indicating poor collateral flow can prevent catastrophic hand ischemia if that vessel were to be occluded. If the radial artery is compromised, the thumb and thenar eminence are often most vulnerable as they are furthest from the ulnar supply.
Okay, so it's a safety check. What about the original versus the modified test?
Right. The original Allen test, first described way back in 1929 by Dr. Edgar Van Wys Allen, involved instructing the patient to elevate both arms and clench their fists for about 30 seconds to exsanguinate the hands. The examiner would then simultaneously occlude both radial arteries, the patient would open their hands, and the color return was compared between the palms. This was then repeated, occluding the ulnar arteries.
Sounds a bit cumbersome.
It was, which is why the modified Allen test, developed in 1952 by Dr. Irving Wright, is the preferred and far more common method in contemporary medical practice. It assesses one hand at a time, providing a more focused evaluation.
So how is the modified Allen test precisely performed in the clinic? What are we looking for in terms of a normal or abnormal result? And what does a negative test truly signify for you as a clinician?
In the modified Allen test, the procedure is as follows. The patient first clenches their fist tightly for about 30 seconds. This helps exsanguinate the hand. While the hand is still elevated, the examiner then simultaneously compresses both the ulnar and radial arteries firmly at the wrist. With the hand still elevated, the patient unclenches their fist. The palm should appear blanched or completely white, indicating effective occlusion of both arteries. Then, and this is the key step, the compression on the ulnar artery is released while maintaining firm pressure on the radial artery.
Okay, release one, hold the other.
Precisely. For a normal or positive test, indicating adequate collateral circulation via the ulnar artery, the color should return to the palm relatively quickly, typically within 5 to 15 seconds in a normothermic patient. If pallor persists beyond 15 seconds, it's considered a negative test. This suggests insufficient ulnar artery supply to perfuse the hand if the radial artery were to be compromised.
And a negative test is a definite stop sign.
A negative test is an absolute red flag, yes. It means proceeding with radial artery compromise could lead to hand ischemia. The procedure can then be repeated on the same hand, this time releasing the radial artery first while continuing to compress the ulnar artery to assess collateral flow specifically via the radial artery. This bilateral assessment ensures a comprehensive understanding of the collateral network.
It sounds straightforward in principle, but you alluded to some debate earlier. What are your thoughts on its accuracy and utility in light of that? And crucially, are there any adjuncts that can enhance its reliability, particularly given its critical role in preventing serious complications? Where do clinicians often go wrong here?
Indeed, despite its widespread use, the utility and accuracy of the modified Allen test have been questioned in some contexts. And this is where clinicians can sometimes fall into pitfalls. For example, a 2017 meta-analysis reported a specificity of 93%, which is good, but an inter-observer agreement rate of only about 71.5%.
So different people get different results sometimes.
Exactly. That variability in agreement across different examiners is a significant concern about its consistency and overall utility. Historically, some studies have even shown that permanent ischemic sequelae occurred despite a seemingly normal Allen test, and its results didn't always correlate perfectly with distal blood flow shown by more objective measures. So while it's a quick test, it's not infallible.
So what's the bottom line for practice?
Well, a more recent study has demonstrated a high negative predictive value. This suggests that a negative test is a strong indicator of inadequate circulation and should certainly not be ignored. The key takeaway here for clinicians is, while a positive test is reassuring, it's not an absolute guarantee, and a negative result absolutely warrants further objective evaluation before proceeding with any procedure that might compromise the vessel.
And common pitfalls.
Where clinicians often go wrong is either not applying enough pressure to fully occlude the arteries initially, or perhaps not waiting long enough for the blanching to be complete before releasing pressure. Both can lead to a false positive result, a false sense of security.
Okay. Are there ways to make it more objective?
Yes, absolutely. To improve accuracy and provide a more objective assessment, clinicians can use supplemental instrumentation. A Doppler probe placed on the thenar eminence can detect blood flow audibly, providing an objective auditory signal of returning flow. Or, perhaps more simply, a pulse oximeter can be placed on the thumb or index finger.
How does that work?
You record the baseline oxygen saturation and waveform, then apply compression to both arteries until the waveform disappears and saturation drops. Then you release the ulnar artery pressure. Observing the return of saturation in the waveform to baseline indicates adequate collateral flow via the ulnar artery.
Ah, giving you a number and a visual confirmation.
Precisely. This objective, quantitative measure significantly enhances the reliability of the assessment. The most significant risk that this test, when performed and interpreted correctly, and ideally with an adjunct, mitigates is catastrophic hand ischemia and tissue loss if radial or ulnar artery circulation is compromised without sufficient collateral supply. It's truly about safeguarding hand viability. 4. Advanced vascular evaluation techniques for the upper limb.
Building on those foundational clinical assessments, technology plays an increasingly vital role in evaluating hand vascularity. How do tools like handheld Doppler and particularly advanced ultrasound mapping enhance our diagnostic capabilities, offering a more detailed, almost three-dimensional picture of the patient's vascular status?
Handheld Doppler units are truly invaluable tools. They offer a quick, portable, and non-invasive means to detect blood flow and assess peripheral vascular status right at the bedside or in the clinic. They operate by transmitting high-frequency sound waves, typically 8-10 MHz, that reflect off moving blood cells. Any change in frequency between the transmitted and reflected signals indicates blood flow, producing an audible signal, that characteristic pulsating or swooshing sound, that tells the operator if flow is present and gives a sense of its quality.
Like listening to the blood flow.
Exactly. While commonly used for ankle brachial pressure index, or ABPI, measurements in the lower limbs, the principles extend directly to the upper limbs for assessing arterial circulation. For instance, in patients with diabetes, calcified arteries are common. This makes the arterial wall rigid and resistant to external compression by a blood pressure cuff. In such cases, a traditional cuff may measure the stiffness of the artery rather than true blood pressure, leading to abnormally high pressure readings, often over 1.3 for ABPI, which makes standard ABPI unreliable for assessing peripheral vascular disease.
So the number itself can be misleading.
It can be highly misleading in those cases. But here, the Doppler remains crucial. It can still distinguish between a normal triphasic waveform, indicating healthy, high-resistance flow, and damped monophasic signals, which clearly indicate significant arterial disease even when the pressure index itself is unreliable. It allows for a quick identification of patients needing further, more comprehensive investigation. It's like having a trained ear that can discern the quality of flow, not just its presence or a pressure reading.
So a handheld Doppler gives us that initial qualitative feel for flow. But then for a truly detailed quantitative picture, especially when we're planning complex interventions like vascular access for hemodialysis, it sounds like formal ultrasound mapping is essential. How does that provide such a comprehensive view?
That's where ultrasound mapping really shines, yes. It offers a comprehensive, non-invasive assessment of the upper limb's arterial and venous network. It provides detailed morphological and hemodynamic information that is absolutely crucial for planning interventions, particularly for vascular access, like hemodialysis fistulas. But the principles are widely applicable across hand surgery whenever vessel assessment is needed. We utilize three main applications to build this detailed picture. Firstly, B-mode ultrasound. This provides a two-dimensional grayscale image.
The standard black and white picture.
That's right. It allows us to study vessel morphology, identify any anomalies like a proximal radial artery bifurcation, which occurs in up to 15% of cases and means a double artery in the arm that you need to be aware of, and precisely measure vessel diameters. These diameters are key predictive factors for successful outcomes. Secondly, pulse wave Doppler, or PWD. This records velocity over time curves, analyzing the precise velocities of red blood cells within the vessels. This is essential for quantifying flow and assessing stenosis. Thirdly, color Doppler, or CD sampling. This reproduces real-time mean velocities, visually identifying the direction and presence of blood flow within a color box.
Showing flow in red and blue.
Typically, yes, depending on the machine settings for flow towards or away from the probe. It helps in quickly identifying areas of interest like increased flow velocity that might suggest a stenosis, which shows up as aliasing, or changing color and pattern. The examination is performed with ample gel to ensure good contact and avoid excessive pressure which could collapse superficial veins. Ideally with the patient supine and the arm relaxed, or maybe the head of the bed raised slightly for venous assessment to ensure optimal venous filling. This comprehensive approach gives us all the data we need.
Could you elaborate on how the arterial and venous examinations are specifically conducted with ultrasound? What key parameters are clinicians looking for in each to inform their clinical decisions? What are the main takeaways for a surgeon planning an intervention?
Certainly. For the arterial examination, we use a high-resolution probe, typically 7.5 20 millihertz, to systematically assess the subclavian, axillary, brachial, radial, and ulnar arteries. We begin with transverse views to accurately measure diameters, identify any calcifications within the vessel walls, and note anomalies like that proximal radial artery bifurcation. Dynamically, we use color Doppler to identify areas of increased flow velocity, which can indicate a stenosis. These areas are then quantified with spectral Doppler to determine the peak systolic velocity, or PSV. This helps us assess the degree of any existing stenosis.
Looking for those narrowed segments.
Exactly. Under normal conditions, the Doppler wave should exhibit a triphasic morphology. That's a high-resistance flow pattern characterized by a sudden systolic peak, a rapid fall, a brief reverse flow component, and then a small forward flow component in late diastole. This pattern should be consistent throughout the arterial tree from proximal to distal. A change to a monophasic or biphasic pattern can indicate disease. A crucial functional assessment is the response to reactive hyperemia.
How do you do that?
We induce temporary hand ischemia, usually by having the patient clench their fist tightly for about 2 minutes, or sometimes using a cuff. Then we evaluate the artery's ability to dilate and increase flow upon reperfusion. A significant increase in PSV and, more importantly, a decrease in the resistive index, or RI, to below 0.7 after the hyperemia test is considered a sign of good prognosis for vascular procedures, particularly for vascular access. It indicates good arterial adaptive capacity.
It shows the artery can open up when needed.
Precisely. It tells us how well the artery can turn on the tap when needed, which is vital for postoperative success, especially for fistula maturation. Now, for the venous examination. This is often the most time-consuming yet critical part, especially for fistula planning, due to its importance in ensuring adequate venous drainage. We explore both the superficial, the cephalic and basilic veins, and the deep venous systems, from the wrist all the way up to the central veins like the axillary and subclavian. Key qualities assessed include vessel patency. This is confirmed by its compressibility. With the probe, a healthy vein should collapse easily and modulation on spectral Doppler after distal compression. You should see a clear surge on color Doppler after squeezing the forearm distally, checking it's open and responsive. Exactly. We also look at distensibility. This is the vein's ability to dilate under increased pressure. We measure the percentage increase in diameter after applying a proximal tourniquet or cuff. An increase above 48% is generally considered a good prognostic sign. This tells us if the vein has enough stretch to handle increased blood flow from an AV fistula.
So looking for a vein that can enlarge properly.
Yes. We also carefully look for wall thickening from past phlebitis or thrombosis, significant caliber changes, and specifically note vein depth and the location of communicating veins in the antecubital fossa, as these are critical anatomical details for planning surgical access. For central venous patency, checking the large veins near the shoulder and chest, which can be difficult to visualize directly due to their depth and location behind bone, we rely on indirect signs on the Doppler waveform.
What sort of signs?
These include respiratory physicity, how the blood flow in the vein changes rhythmically with breathing, normally increasing with deep inspiration due to negative thoracic pressure, and transmitted cardiac pulsatility, those subtle waves on the Doppler curve reflecting the heartbeat, especially in veins closer to the heart. Their absence, or a flat, non-phasic, non-pulsatile flow curve in these central veins, can be a red flag. It might indicate stenosis or occlusion deeper in the system, perhaps from a previous central line.
So, these incredibly detailed ultrasound parameters, coupled with the initial clinical findings, truly help predict the success of these often complex vascular procedures, ensuring the best possible patient outcomes. It sounds like you're building a complete vascular profile before any intervention.
Precisely. These objective ultrasound measurements provide highly valuable predictive factors for vascular access success and, by extension, other hand vascular surgeries. Major predictive factors include a vein diameter of greater than 2.0 millimeters, sometimes even 2.5 millimeters depending on the study, and an arterial diameter also greater than 2.0 millimeters. You combine that with good venous distensibility, ideally that increase above 48% after a proximal cuff, and confirmation of central venous patency through those indirect signs. While the absolute values can vary slightly between studies, the general consensus is clear. Larger, more distensible vessels with good flow dynamics have a significantly better prognosis for successful maturation and long-term function. They're simply better equipped to handle the increased demand.
Makes sense. Bigger pipes work better.
Essentially, yes. Minor factors that contribute to this predictive mosaic include the peak systolic velocity, PSV, of the arteries, the resistive index response to the hyperemia test, and even arterial wall thickness, or intima media thickness, IMT, which is a known marker of cardiovascular risk. Although IMT is not routinely part of presurgical mapping for fistulas, its presence, if noted, can influence the overall assessment of vessel health and long-term patency. It really underscores the importance of a thorough, objective, preoperative mapping strategy. This multidisciplinary approach, integrating detailed clinical history, physical examination, and advanced ultrasound mapping, ensures we make the most informed decisions for each patient. It optimizes the chances of a successful and durable outcome. It's truly moving beyond guesswork to evidence-based planning, V-hand ischemia, and digital replantation. Complex challenges and ethical considerations.
Building on our understanding of vascular assessment, let's turn now to more critical scenarios. Specifically, hand ischemia and the complex, often dramatic decisions surrounding digital replantation. This is frequently a time-sensitive presentation with profound implications for a patient's life, isn't it? How does severe hand ischemia typically manifest? And what are its common causes that clinicians need to be acutely aware of?
Hand ischemia signifies an inadequate supply of blood and oxygen to the hand, often due to a blocked or severely constricted blood vessel. The symptoms are typically quite distressing for the patient and usually present a clear clinical picture. They generally include fingers that are painfully cold, numb, or pale. This often progresses to a bluish discoloration as deoxygenation sets in. A hallmark clinical sign that demands immediate attention is small wounds or simple cuts that fail to heal. They just seem to fester, turning into painful ulcerations, particularly on the fingertips.
That non-healing wound seems key.
It really is. I've seen countless patients come in with what they describe as a paper cut that won't resolve, only for investigation to reveal significant underlying ischemia. The causes of hand ischemia are diverse. Raynaud's disease, particularly its secondary form associated with connective tissue diseases like systemic sclerosis or lupus, can certainly lead to severe ischemia and persistent fingertip sores. Occlusive disease is another common cause. This typically results from either a direct injury to the vessel or some form of swelling or inflammation within the vessel wall, which can lead to the formation of blood clots and turbulent blood flow. This often presents with those characteristic non-healing wounds. Atherosclerosis, or hardening of the arteries, can also significantly reduce circulation. While we think of it more commonly affecting the legs, it can definitely impact the arms, leading to widespread calcium deposits that stiffen and narrow blood vessels.
And certain patient groups are more susceptible.
Yes, patients with multiple comorbidities, such as diabetes and chronic kidney disease requiring dialysis, are particularly susceptible to severe hand ischemia. Interestingly, their hand symptoms can sometimes be overshadowed or perhaps deprioritized by their more acute systemic issues during hospital admissions. This can make diagnosis and timely intervention challenging, a real diagnostic trap if you're not vigilant and specifically ask about hand symptoms.
When hand ischemia is severe, perhaps due to trauma leading to amputation, sometimes the only option considered is replantation of the digit. This is a topic that stirs a lot of discussion, not just clinically but also ethically. Could you outline the absolute and relative indications for digital replantation, guiding us through these critical decision points for surgeons?
Digital replantation, first successfully performed way back in 1965, has evolved significantly since then. Our understanding has really shifted. It's moved from simply achieving digital viability, just getting the digit to survive, to prioritizing functional outcome and patient satisfaction. We now have clearer indications to guide these complex surgical decisions, aiming for a meaningful return of function.
So survival isn't enough. It has to work.
Precisely. Absolute indications where replantation is almost always attempted due to the severe functional impact of loss include, firstly, amputation of the thumb, regardless of the level. The thumb's critical role in grip and opposition contributes nearly half of total hand function, and its loss is functionally devastating. Losing a thumb is, in many ways, like losing half your hand's capability. Secondly, amputation of multiple digits. The loss of several digits severely compromises global hand function. In these cases, even complex reconstructions, like transposing amputated digits or using spare parts from less salvageable digits to reconstruct a more functional hand, are often warranted. Thirdly, amputation in a pediatric patient. Children have superior biological healing potential, better nerve regeneration, and a longer life expectancy, so the indications for replantation in children are typically much more aggressive. We might even attempt replantation in situations that would be contraindicated in adults, despite the higher technical challenges posed by their smaller vessels.
That makes perfect sense, especially considering the long-term functional implications for children and their amazing healing potential. What about the relative indications? And then crucially, the contraindications for replantation, both absolute and relative, that help surgeons decide when not to proceed.
Relative indications are, as you suggest, more nuanced. They depend heavily on shared decision-making with the patient and their individual circumstances. These typically include single-digit amputations distal to Verdam's zone 2. That's a specific anatomical area of the finger, distal to where both flexor tendons run together within the tight fibrous sheath, but proximal to the FTP insertion.
Why is that zone important?
Because the surgical repair here is generally less complex than in the notorious no man's land, more proximally that zone 2 itself, where both tendons are running within that tight sheath.
Yeah.
Repair in zone 2 has a higher risk of adhesion formation and stiffness, making functional outcomes less predictable. So distal to zone 2 is relatively more favorable. Patient wishes, often influenced by cultural, religious, or occupational needs, are also a significant relative indication that must be respected and factored into the decision.
Right. And the reasons not to replant.
On the flip side, contraindications are critical for patient safety and the realistic prospect of a successful functional outcome. Absolute contraindications, where replantation should generally not proceed, include situations where the procedure poses a direct threat to the patient's survival. This can occur in critically unstable patients due to polytrauma or severe underlying medical issues. A prolonged, complex microsurgical procedure would simply be too risky and could compromise the patient's life. Also, if the amputated part itself has a segmental injury, meaning multiple levels of damage or unsuitable vessels for repair, perhaps due to avulsion or severe crush. If there's severe mangling, or if the ischemia time exceeds the window of viability.
How long is that window?
It varies depending on the tissue type and temperature. Muscle tolerates warm ischemia poorly, maybe only 6 hours, while digits with mostly tendon and bone can tolerate longer, perhaps 12 hours warm or even 24 hours if effectively cooled. But exceeding these limits drastically reduces the chances of success. A severe crush injury, for example, might cause such extensive tissue damage that successful revascularization and long-term viability are impossible, even if the vessels initially seem repairable.
Okay, those are the absolute stops. What about relative contraindications?
Relative contraindications require very careful consideration and a thorough discussion between the surgeon and the patient. These include single-digit amputations in Verdam's zone 2, which, as I mentioned, are surgically more complex due to the presence of both flexor tendons within the sheath, making good functional outcomes less predictable and increasing the risk of stiffness. Various patient factors also play a crucial role. Significant psychiatric illness, self-inflicted injuries, which raise questions about compliance and future risk, active smoking status, which severely compromises microvascular healing, poorly controlled diabetes mellitus, and significant peripheral vascular disease all increase the risk of failure and complications. Furthermore, socioeconomic factors must be considered. Can the patient attend the rigorous, often lengthy postoperative rehabilitation? Can they take sufficient time off work to recover properly? These practicalities are vital. Each of these individual patient characteristics must be weighed carefully against the potential benefits of replantation, ensuring that the decision is truly in the patient's best interest for functional recovery. It's never just a technical decision. It's deeply personal and functional.
It sounds like an incredibly complex balance of technical possibility, patient factors, and deeply personal considerations. With such demanding procedures, what factors do we know from clinical experience and studies predict success, distinguishing between mere survival of the digit and a truly functional recovery?
When considering replantation, evaluating the chances of success is indeed vital, although, as we've said, success itself is a complex concept. Digital viability, the digit surviving, is not the same as functional success. Functional success incorporates patient-reported outcomes, pain levels, sensation, movement, and a meaningful return to function useful for daily life. Retrospective reviews have shown varying overall survival rates for the digit at discharge, ranging from around 68% in a UK series to 71% in a Canadian series. So survival is reasonably good, but not guaranteed. But what about function?
Yes, the function is key.
Factors positively predicting success, particularly functional success, tend to include a sharp mechanism of injury, like a clean guillotine-type cut. This causes less associated vascular and soft tissue damage compared to a crush or avulsion injury. Intact venous drainage in partial amputations is also a strong positive predictor. Venous congestion is a major cause of replant failure. If blood can't get out effectively, the replant won't survive long. A more proximal injury can sometimes predict better technical success due to larger, more robust vessels that are technically easier to repair microsurgically, though nerve recovery might be less complete. And interestingly, post-operative aspirin use has been noted as a positive factor, likely due to its antiplatelet effects, helping to keep those delicate microvascular anastomoses open. Surgical shortening of the digit at the time of surgery can also increase success rates by allowing for a tension-free repair of vessels and nerves and removal of any marginally damaged tissue at the amputation edge.
And factors predicting failure.
Conversely, things like the need for leeches postoperatively to manage venous congestion, which is already a sign of venous outflow problems, or the need for re-exploration due to complications like thrombosis, were found to predict failure. It's important to recognize that the heterogeneity of patients means no single factor guarantees success. Some studies, in fact, have found no single significant predictive factor when looking at large cohorts, underscoring this complexity. It really pushes the need for thorough, individualized assessment and meticulous surgical technique.
That's a fascinating look at the medical and surgical aspects, particularly that crucial distinction between survival and function. Before we wrap up, it's worth touching on the ethical dimension. In such high-stakes, time-sensitive trauma situations, how do clinicians navigate the process of obtaining truly informed consent from patients who are often in immense distress and facing a life-altering decision?
The ethical implications of obtaining truly informed consent in such traumatic, time-sensitive situations are indeed significant and pose a unique challenge for us. Patients presenting with an amputated digit are often experiencing intense physical pain and profound psychological stress, shock, fear, anxiety. It severely limits their capacity to fully process and understand the complex information being presented.
They're hardly in a state to weigh complex medical options calmly.
Exactly. They have very limited time, sometimes just hours, to consider choices regarding risks, benefits, and alternatives of replantation versus revision amputation, choices that will have profound, lifelong consequences for their hand function, their appearance, their work, their overall quality of life. It is absolutely critical for the surgeon and the entire medical team to counsel patients in as calm and clear an environment as possible. We must strive for genuine shared decision-making. This means going beyond just listing risks like infection or failure. It's about presenting the realistic probabilities of success, not just in terms of digital survival, but also the anticipated functional recovery, what level of sensation might return, how much movement, will there be chronic pain, and explaining the arduous, often multi-year rehabilitation process involved. You have to paint a realistic picture of what life could look like after each choice.
Managing expectations realistically sounds vital.
Absolutely. This is particularly challenging and requires great clinical judgment when indications and contraindications coexist. Imagine that thumb amputation an absolute indication, but the digit has also sustained a severe crush injury, which is a relative contraindication due to the extensive tissue damage and poor prognosis for function. In such scenarios, the surgeon must transparently discuss these conflicting factors with the patient and often their family. It's a collaborative process to determine whether the potential benefits of the indication truly outweigh the risks posed by the contraindication, or vice versa. It's about ensuring that the patient's values, their understanding of the very real trade-offs, and their realistic expectations guide the final decision. For truly patient-centered care, even in the most acute and stressful circumstances, it's not just about what we technically can do, but what is genuinely the best path for that specific patient. And often, psychological support, both immediate and long-term, is just as crucial as the surgery itself. Outro.
Well, that was a truly comprehensive deep dive into the complex world of hand vascular health. We've covered so much ground. Everything from the fundamental anatomy and those crucial quick clinical assessments like capillary refill time, to the intricacies of Raynaud's phenomenon, the critical Allen test and its adjuncts, advanced ultrasound diagnostics for preoperative mapping, and of course the challenging yet immensely rewarding field of digital replantation, including those vital ethical considerations around consent.
It really highlights just how interconnected vascular health is with overall hand function, doesn't it? You can see why a detailed, multimodal approach to assessment and treatment, integrating both clinical acumen and objective technological insights, is absolutely essential for optimal patient outcomes in orthopedic and hand surgery. The hand truly is a microcosm of the body's vascular system, and often an indicator of systemic health, too.
Absolutely. The evolution of microvascular techniques, combined with an ever-deepening understanding of patient-centered outcomes, continues to shape this dynamic field. It's a constant learning curve, balancing what's technically possible with what truly provides the best quality of life for the patient. Perhaps a final thought for you, our listeners, to consider. How might emerging technologies like AI-assisted diagnostics, or perhaps even advanced biofringing techniques, one day shift our paradigms, not just in assessing, but maybe even in regenerating damaged hand vasculature in the future? It's certainly a fascinating area to ponder. If you found this deep dive valuable, do consider leaving us a rating and perhaps sharing it with a colleague who might also benefit from this discussion. We'll be back soon with another deep dive into a crucial topic in orthopedics. Until then, keep those hands healthy and keep learning.